Okay, so I think folks are still rolling in, but we'll get started. This is a very exciting pair of presentations, and we're really happy to have Drs. Ishrat Husain and Josh Rosenblat joining us, both from the University of Toronto. I'll give specific bio introductions on each of them, but suffice it to say that this is, I think, upcoming leaders in our field, focused on the most novel interventions for some of the most pressing challenges in the field of mood disorders. And I was thinking about like analogies. So is this like Rafa Nadal and Roger Federer, or what kind of pairing would you think? But this is, I think, two upcoming superstars who happen to both be highly innovative thinkers, extremely meticulous in their methodology, and also get along with each other. So, personally, I'm very excited to see what the future holds for the field, for Toronto, and for these two clinician scientists. So to start off with, Dr. Ishrat Husain is head of the newly founded Clinical Trials Unit at CAMH and heads the Mood Disorder Service here. He also serves as Associate Professor in the Department of Psychiatry at University of Toronto, holding a Tier 2 Canada Research Chair for Treatment Innovation in Mood Disorders. Dr. Husain's research program focuses on advancing the understanding and treatment of mood disorders across populations in Canada and beyond through clinical trials of emerging pharmacological and psychosocial interventions, including, as we're going to hear today, about psychedelics. So over to you, Ishrat, to kick us off.
Thanks a lot for the kind introduction, Ben. I'm just going to share my screen, get my slides up. Okay, and it's a real pleasure to be here and share the virtual stage with my friend and colleague, Josh. As you'll see that Josh and I are collaborating on a number of different trials for these emerging treatments for mood disorders, and I'll be speaking about some of that work today. For the next 20 minutes, I'm going to be talking about psilocybin therapy as an emerging treatment for both unipolar and bipolar depression, specifically, given that this is the bipolar research rounds. In terms of disclosures, I have led contracted research for Compass Pathfinder, who are an industry sponsor of psychedelic research. I've also served as an advisor to various psychedelic startups, but there's no conflict of interest with the talk that I'm about to give. In terms of learning objectives, I'm going to start off by describing briefly the psychopharmacology of psychedelic drugs and what they are. The term psychedelic is bandied about quite frequently, oftentimes without a clear definition of what these compounds comprise of. And then what I'm going to do is evaluate current evidence on the safety and efficacy of psilocybin therapy on clinical outcomes in mood disorders, and then conclude by identifying areas of further research that we're hoping to address before psilocybin therapy can be translated to our clinics. So these are just some grabs, screenshots of media outlets like The Guardian in the UK, the New York Times in the US, really kind of showcasing that psychedelic therapies are probably the most discussed subject relating to mental health at the moment, not only in the clinical research sphere, but also I think in the public domain. To just give you an example of this, earlier this week, I was at what's probably a health spa called Othership. And even during my time there, which comprises sauna and ice baths, they were talking about transcendence, journeys, sort of elevating your mental wellness. And the amount of conversations I was overhearing about people microdosing and so on was really remarkable. So this is something that really has entered public discourse, and it's something that we as clinicians really should be aware about in terms of the current evidence base for their therapeutic use. But where did all this attention come from? It's probably because people with quite captive audiences and large platforms are speaking about the potential benefits of psychedelics as therapeutics. The book on the left there is a best-selling a chronicle, really, of Michael Pollan, an investigative journalist's own use of psychedelics like psilocybin and the potential benefits that they could have. The gentleman on the right, Tim Ferriss, is a prominent podcaster. He makes his a sort of living by interviewing high performers. He's also a best-selling author, and he's spoken about his struggles with treatment-resistant depression and how he's not had a recurrence of his depressive illness since he's integrated psychedelics into his own treatment. So this has created quite a lot of buzz and hype within the public and patient groups as well. But what exactly is psychedelic? It's actually a neologism. It was a term coined by a Canadian psychiatrist, Humphrey Osmond, to describe these substances that have quite potent psychoactive effects. In ancient Greek, it means mind revealing or mind manifesting. Prior to the term psychedelic being coined, they were often referred to as psychotomimetics, which wasn't thought to be quite appropriate or accurate in terms of what the psychological and emotional effects of these substances was. So hence the term psychedelic. In terms of what the classification is, it's not a formal drug classification. It's a group of compounds that produces profound psychological effects that are characterized by altered states of perception, consciousness, and changes to thoughts, feelings, and mood. Really also characterized by quite profound spiritual and mystical experiences. When I'll be talking about them, I'm primarily focused on psilocybin, but generally I classify psychedelics as those that have a serotonergic action, and I'll talk about that in a second. Ketamine, which Josh will be speaking about later, I consider to be more dissociative anesthetic and not a psychedelic, particularly in the way that treatment is also delivered as well. In terms of the history of psychedelic drugs, the gentleman pictured here is Albert Hofmann. Some consider him as sort of the grandfather of the psychedelic movement. He, in the late 1930s, synthesized LSD while working at a Swiss pharmaceutical company called Sandoz. And about 20 years later, he isolated psilocybin from the Psilocybe genus of mushrooms. And actually, Sandoz in the 50s and 60s marketed both these drugs as indocybin for psilocybin and delicid for LSD. And around that time, the NIH was generously funding research on the therapeutic uses of these compounds for various mental disorders and addictions as well. However, they quickly slipped into recreational use, became associated with the anti-Vietnam War movement, and the Nixon administration classified them as controlled substances. And in 1971, they were classified under Schedule 1, and that's despite very little evidence of harm at that time. In terms of the pharmacology, I spoke about serotonin and the classic psychedelics like psilocybin and LSD have quite potent actions at the 5-HT2A receptor. We know that this agonism of the 2A receptor is what's responsible for the psychedelic effects, which include the altered states of perception and changes to consciousness as well. However, they aren't very clean drugs. They also have actions at other serotonin receptors, including the 1A and the 2B receptors. MDMA is a little bit different in its actions. It causes the presynaptic release of serotonin as well as norepinephrine and dopamine. This table nicely summarizes some of the pharmacodynamics and pharmacokinetics of the classic serotonergic psychedelics. You can see generally the duration of action is anywhere from 4 to 6 hours, longer for LSD, up to 12 hours, which is why probably there's fewer clinical trials of LSD. You can imagine if you need to administer these substances with continuous monitoring, it would be hard to do that for 12 hours straight. And then ayahuasca in its smoked form tends to have a much shorter duration of action of around 5 to 20 minutes as well. Most are taken orally, in terms of their administration. I spoke about the powerful psychological effects of these substances, and this is just a list of them. You can see that a lot of them sound very pleasant: enhanced sociality, feeling close to others, emotional empathy, feelings of bliss, the sensation of synesthesia, which is the ability to see sounds, which is why music is considered to be quite a critical part of the intervention. It can, however, be also quite negative at times. There can be anxiety, fear, panic, dysphoria, as well as frank paranoia and auditory hallucinations, although this is very rare with MDMA and only considered to be the case at very, very high doses. In terms of adverse effects, this is data from recreational users, which reports around 40% of recreational users have some adverse effects. Generally, these are mild and transient. You can see them listed there: mild hypertension, some nausea, dizziness, pupil dilation. Although 7.6, so almost 8% of people also report enduring psychological symptoms following recreational use of psychedelics. So after the classifications of these substances as Schedule I narcotics, you can see that there was an almost 3-decade cessation of clinical research into their therapeutic use. But then in the late 2000s, 2010s, you can see that groups in the US and UK again began to investigate substances like psilocybin, DMT, as potential therapeutics for various mental disorders, OCD, existential distress associated with terminal cancer, and addictions, including alcohol and tobacco use. And then in 2016, there was a quite seminal paper, an open label trial published in Lancet Psychiatry by the group at Imperial College in 19 patients with treatment-resistant depression using psilocybin with accompanying psychological support, showing quite large and sustained antidepressant effects. And critically, at that point, there was no real adverse events reported in any of the clinical trials. And these are some of those early signals of psilocybin and its antidepressant effects in populations like those with terminal cancer and treatment-resistant depression. You can see here from these graphs, the sort of images kind of speak for themselves in terms of the large reductions in depressive symptom rating scales. So the treatment experience with psilocybin is quite different from the traditional pharmacotherapies that we usually employ in our practice. This is a picture of the previous CAMH psilocybin dosing room. You can see it's a non-clinical space. Generally, patients have to be prepared and screened quite thoroughly for the treatment. That includes an assessment of any physical or psychological comorbidities. Patients with schizophrenia and bipolar I disorder are excluded from psilocybin treatment at the moment. We do taper patients off of serotonergic medications as well, because this is thought to interfere with the effects of psilocybin, although recent work has indicated that you can use psilocybin in combination with SSRIs, albeit the antidepressant effects may be milder in those situations. And then preparation as part of the intervention is very important, providing patients with psychoeducation on what the treatment encompasses, how they should prepare for it, and how they should integrate the experiences post-dosing as well. And then the actual dosing day itself lasts anywhere from 5 to 8 hours in this non-clinical setting with ambient lights and music as well, and 2 trained therapists that are there throughout the day. So psychological support is something that is considered to be key, not only for safety, but also to maximize efficacy. And all published clinical trials of psilocybin therapy have used it in combination with some degree of psychological support. It usually involves at least 3 hours of preparation, up to 8 hours of support during the dosing session with music, and then some integrations post-dosing as well. It's believed that the psychological support component is related to acceptance and commitment therapy, with this emphasis on psychological flexibility. It's been shown in small secondary analysis of studies that setting an intention before dosing and having a sense of support or trust with the therapist is associated with positive outcomes, as well as music being associated with positive outcomes as well. I mentioned that 2 therapists are present. Really, their job during the actual dosing session is to witness the participants' process and to provide, support and respond to any changes in their mental or physical state at that point. So, since that initial trial led by the Imperial College Group in 2016, there has been at least one clinical trial, at least over the last 4 years, published every year, looking at the therapeutic effects of psilocybin therapy in depression, including in populations with life-threatening cancer, MDD, and more recently bipolar II disorder as well. And this was work led by Josh's group over at UHN, in which they synthesized evidence from all published clinical trials of psilocybin for the treatment of depressive symptoms, showing that really the pooled effect size was large at 0.75, which, if you look at pooled evidence for the antidepressant effect size for SSRIs at 0.3, it is certainly something that's much larger than what we currently use. And then again, in life-threatening cancer, very large effect sizes of around 0.96. The issue often raised with clinical trials of psychedelics includes what the control arm should be. It's very difficult to adequately blind the powerful psychoactive effects of these substances. And what I really liked about this particular meta-analysis was that Josh and co. also looked at the impact of the control arm on the effect size. And it seems to me that using an active comparator, or a low dose of psilocybin is probably the best way to control, because you can see that the effect size is somewhat attenuated in those populations compared with placebo, an inert placebo, where the effect size is still much larger. So moving on to the use of psilocybin in bipolar disorder, this was an interesting survey led by colleagues in UBC, in which they surveyed over 500 individuals with bipolar 1 and 2 disorder who had recreationally used psilocybin. And this was just some of the self-reported adverse effects of recreational psilocybin use in bipolar disorder from this cross-sectional survey. You can see that almost 14% of recreational psilocybin users reported symptoms of mania following recreational psilocybin use, as well as quite a substantial portion who experienced psychotic symptoms as well as insomnia. So this is something that was, again, naturalistic data that was captured from recreational users. We don't know, what exactly they were using and where they were accessing these substances, but it was interesting data nonetheless. And then what I found very interesting as well was the reasons that patients or individuals with bipolar disorder were actually using psilocybin. And it seems that over 60% were using it to sort of self-medicate their own mental health issues, which really speaks to the need and perhaps the desperation of some individuals with refractory symptoms as well. So this leads us on to the clinical use and within clinical research of psilocybin for bipolar disorder. And this was a study published at the end of last year in JAMA Psychiatry by Scott Aronson in the US, He used a proprietary form of synthetic psilocybin, the same form produced by Compass Pathfinder, looking at a single administration of 25 milligrams of psilocybin combined with psychological support for 15 individuals with bipolar 2 disorder and a current major depressive episode that was refractory to treatment. This was in 15 individuals, and the treatment was delivered open label. So, take that with a grain of salt in terms of the appraisal of the findings. But you can see here that these patients were at baseline were quite severely depressed as well, with a baseline MADRS score of over 30. It was quite a homogeneous sample, mostly white Caucasian participants as well. In terms of the results, you can see here seem to replicate a lot of the graphs that we saw earlier in unipolar depression, with quite large and sustained reductions in MADRS scores, sustained up until week 12 following dosing as well. And the self-reported QIDS scores mapped over the clinician-rated MADRS as well. Interestingly, 9 of the 15 individuals in this study were not on any mood stabilizer until after the trial at week 12. However, 6 did start some mood stabilizing treatment due to a recurrence of their mood symptoms, which may indicate that perhaps one dose may not be enough. Okay, and then I've got to give a shout out to this. This is very fresh, hot off the press, led by Dr. Rosenblat and colleagues. This is the first Canadian trial of psilocybin therapy for treatment-resistant depression, published yesterday. It's a pilot trial in 30 participants, which comprised 4 individuals with bipolar 2 disorder as well, which was important data really to add on to Scott Aronson's trial to show that psilocybin therapy can lead to improvements in depressive symptoms in individuals with bipolar depression as well. And importantly, without a recurrence of manic symptoms, as was the case with the Aronson trial as well. In terms of the mechanism of antidepressant effects, this is still an area of active study. It could be that the antidepressant effect is due to the direct 5-HT2A activation. It could be a biopsychosocial spiritual downstream effect of that acute psychedelic experience. We know that these psychedelics cause neuroplasticity and can cause changes in the default mode network. So this may be contributing as well. They also, interestingly, have anti-inflammatory and antioxidant effects. And we know a subset of individuals with unipolar and bipolar refractory depression have an activated immune system. So that may be contributing as well. And we can't, leave the discussion without talking about the potential effects of placebo and expectancy and how that may be playing a role in some of the results we're seeing. Okay, I'm just going to move on quickly because I understand Josh is coming up next. This is just some data showing that perhaps psilocybin therapy increases connectivity across regions in the brain. This is work from the Imperial College group, pooling together data from fMRI scans from their 2 previous trials. Importantly, there's been no significant adverse events in any of the psilocybin trials. However, in the large phase 2 trial in treatment-resistant depression, there was a numerically higher number of individuals with suicidal ideation in the high-dose psilocybin arm, most of whom were non-responders to that treatment. Again, perhaps a role for expectancy there. There's a lot of limitations with current studies, including small sample sizes, expectancy bias, a lack of blinding, homogeneous samples, as well as limited follow-up during the trials. And we still haven't understood what the dose-response relationship is and what the actual role of the psychotherapy is as well. Okay, and again, other issues we need to be aware of, the highly motivated patients, therapists have some degree of allegiance bias. Some of them have had their own psychedelic experiences, which really motivates them to get into the field. And this is just a statement from CanMat, in which we appraise the evidence for the use of serotonergic psychedelics, and we still consider them to be experimental treatments at this point, largely restricting their use to clinical trials, and in rare cases through the Special Access Program through Health Canada. Yet, despite this, the psychedelic train keeps rolling. This is an image of a mushroom dispensary just down the street from CAMH, where our patients can readily access it to self-medicate. You can see here headlines showing that even conservative states in the US are moving towards studying the benefits of psychedelics. So it's not going away anywhere anytime soon. Okay, I'm just going to skip to the last slides here because I want to ensure that we have time for Josh's talk. In terms of next steps, we want to look at longer-term follow-up studies. We want to look at associations with dose response, mechanism of actions, trying to understand the role of the psychotherapy component, and then expanding this work to other populations, including bipolar disorder and anxiety disorders, including OCD. Okay, in summary, there's growing evidence for rapid and sustained effects of psilocybin in treatment-resistant depression. However, the treatment is complex. Patients need to be properly screened and prepared. And there's lots of issues with current clinical trials that we need to be aware of when we're discussing results with our patients. And we need further large-scale studies before we can implement this emerging treatment into our practice. Okay. With that, I'll hand it over to Josh and we can have a discussion at the end.
Yeah, thanks so much, Ishrat. I think that we've given you guys both a tough task because you have a lot of data and information to present. So what I'll suggest is that people can write their questions in the chat, and what we'll do is consolidate them, see if we can get Josh and Ishrat to answer them, and then circulate answers if we're not able to have a fulsome discussion at the end. Thank you, Ishrat. So just in terms of introducing Dr. Josh Rosenblat, who I've known for a long time. He works as a clinician scientist at the Mood Disorders Psychopharmacology Unit, together with his longtime mentor and colleague, Roger McIntyre and Rodrigo Mansour, where they conduct novel research on difficult to treat mood disorders using novel agents. In particular, Josh's work focuses on psilocybin-assisted therapy, as we're hearing about, for bipolar and unipolar depression, as well as ketamine and pentoxifylline. Josh completed his residency at the University of Toronto. I had the opportunity to work with him when he was the chief resident for the clinician scientist program. He then went on to do graduate training through the Department of Pharmacology at U of T. And as I mentioned to those who were here in the first few minutes, is beginning this great collaboration with Ishrat on these complementary lines of research, lots of collaboration and innovation. So Josh, over to you, and then hopefully we'll have a couple minutes for discussion in person and the rest virtual.
Thanks so much, Ben. I'm just sharing my slides here. Can you see the full slide?
Full slide looks good.
Okay, perfect. Yeah, so thanks, Ishrat, for really setting the stage and the background on psilocybin. And in my section, I'm going to be presenting a couple specific papers. So there was the broad view and excellent overview from Ishrat, but I want to share with you some local success stories that we've had around investigating psilocybin and ketamine for bipolar depression. So the first study I'm presenting on is the one that Ishrat mentioned, psilocybin-assisted psychotherapy for treatment-resistant depression, a randomized clinical trial evaluating repeated doses of psilocybin. Here are my disclosures. So before diving into the specifics of the study, I did just want to add the sort of Canadian context here that it's very humbling how Canada has lagged behind the rest of the world, in my opinion, in the research and development of psilocybin and psychedelics in general. Where in the States and in Europe, there has been a lot of clinical research, a lot of studies, a lot of development, but in Canada, there was decades of basically zero psilocybin clinical trials until relatively recently. So in 2019, the first Health Canada regulated study was the Compass Industry sponsored study. So for that study, there was 2 Canadian sites, CAMH led by Ishrat, and then the CRTC led by Roger McIntyre. And I believe each site recruited about 3 participants. So most people wouldn't really consider that a Canadian trial since the sponsor was not within Canada, and it was just a couple sites in a larger multi-site study. So I think most people would agree that the first true Canadian study, and certainly the first investigator-initiated study, wasn't until 2021, and that's the BCDF 001 study that I'm sharing with you today. So sponsored by Brain and Cognition Discovery Foundation. And for about 6 months, actually, it was the only psilocybin clinical trial registered in Canada. Now there's over 20 trials that are registered and either ongoing or soon to be starting. So there's been this rapid increase to go from 1 to 20 in the span of just a couple of years. There's also the national interest with the CanMet consensus statement published last year. And then interest grew further as CIHR came forward and said, we want to invest in this. So they had a special call saying that they would give 3 $1 million grants to 3 teams that want to study this area further, which Ishrat and I were lucky to be one of the teams selected to study this further with that federal funding. So very exciting and good timing. Yesterday was the publication of this first Canadian psilocybin clinical trial published in Med. That's a Cell Press journal. And happy to share the full text with anyone that's interested, but I'll just take you through this right now. As you can see, a lot of team members, 37 authors. So it really takes a village to do this type of research. So lots of therapists and researchers. And it was really everyone coming together to accomplish this this clinical trial. Very briefly, here's the clinical trial design, where it was a waitlist control. Important piece of background here is that this trial was actually born out of advocacy, where it came from a single patient of mine that I wanted to provide psilocybin therapy for, and I tried to get them a single exemption, and Health Canada kept saying, do a clinical trial if you want to get access to psilocybin for your patients. So, in discussion with Roger, we carefully reviewed things and we decided, okay, we'll go ahead and we'll do a clinical trial with the first driving factor being to get access for Canadians to psilocybin therapy as the only way to legally access it above ground. And also, of course, to do some good science and build some local infrastructure to allow us to start doing this research and see the explosion of research that has happened. So one of the key things here is that we wanted everyone to have the opportunity to have the actual treatments. That's why this wasn't a placebo-controlled RCT, but it was a waitlist-controlled RCT. So that was very intentional, where we sacrificed, that scientific gold standard for this initial study of a placebo-controlled study to do a waitlist control. So it was either immediate treatment or delayed treatment. Several unique aspects of the study. One was that we had a very brief therapy protocol where it was only one prep session that was 1 to 2 hours, the dosing session a week after, an integration session the day after, and a second integration session the day after. So we call this the 4-session model that we essentially created for the purpose of this study, so that we also wanted to see so that we can improve scalability of this intervention, could be reduce the number of psychotherapy hours so that it's still safe and effective without costing the system, tens of thousands of dollars with all the psychotherapy that has been used in previous clinical trials. Another unique part was that we allowed for flexible repeated doses, which has never been done before globally. And so if someone had a benefit and then relapsed with their depression, then we could give them a second or even a third dose of psilocybin over the course of the 6-month trial. So a number of novel aspects that we had for this trial. But perhaps the most novel aspect was that we had very flexible eligibility criteria. This is the first RCT in the world and the only published RCT in the world to include bipolar 2 disorder, as well as MDD. So the study presented by Ishrat earlier, that was not an RCT, but that was specifically bipolar 2. But this study was the first one that allowed for inclusion of bipolar 2. When we initially submitted the CTA to Health Canada, we actually requested to include bipolar 1 as well. But Health Canada came back and said, show us some safety in bipolar 2 before we allow you to test it in bipolar 1, which I think, allowed us all to sleep a bit better at night, knowing that we were testing it in bipolar 2 first. So we had no one with a history of psychotic features in this trial. But aside from that, I mean, this was treatment resistant. They had to have failed at least 2 medication trials. The eligibility criteria was very flexible. All previous trials excluded people with personality disorders, actively suicidal participants, but we allowed these participants in, and we actively recruited them. So people with comorbid, severe borderline personality, we still enrolled in the study, and people that had a significant suicidality, we still enrolled in the study, where we really wanted to put psilocybin to the test to see in the real world clinical population, is this still going to be safe and effective versus the very strict eligibility criteria that we're all familiar with in standard clinical trials. So I highlighted these aspects that, a number of very novel things. This was done in the community at CRTC or Braxia Health. So that's an important thing too, that, this wasn't done at Imperial College or at Johns Hopkins or at NYU at these sort of fancy ivory tower buildings, but was conducted in the community, which again, from a generalizability and scalability perspective, if this is going to be a game-changing treatment, it's not going to be administered exclusively in these very famous institutions like Johns Hopkins, but should be able to be administered within the community in a community practice clinic's office, for example. We enrolled 30 participants, and as you can see here, the dropout rate to the primary endpoint was very low. So we only had one person drop out before the primary endpoint. Over the course of the 6 months, we had a few more people drop out so that they could start other treatments. But we found that from a acceptability perspective, acceptability was quite good, and that the dropout rate was low. Here's the demographics. Just to bottom line this for you, very chronic depression, averaging around 20 years of depression. So very persistent chronic depression, highly treatment resistant, averaging 10 failed medication trials, and 40% of our population had actually already tried ECT and or ketamine. So a very resistant population. And interestingly, when we looked at the only other RCT in TRD, which was the COMPASS study, 29 out of 30 of our participants would have been excluded from that trial because everyone had more than 4 failed medication trials. So, quite a different population here compared to the previous trials. So the primary outcome was looking at the week 2 endpoint, which has become fairly standard for rapid-acting antidepressants such as psilocybin and ketamine. So it's not the 8-week trials or the 12-week trials that we're used to with antidepressant and mood stabilizers. We found, compared to waitlist, there was a rapid and robust antidepressant effect, as shown by the orange line here, compared to the waitlist period. So we were able to observe efficacy, even though this was a feasibility study. Efficacy wasn't the primary outcome, and we weren't powering ourselves for efficacy, but nevertheless, we still were able to find efficacy with p-value less than 0.05, and also a very clinically significant difference between groups. Now, this is bipolar round, so this is really the part I wanted to highlight strongly. Our subgroup with bipolar was only 4 participants. We learned that it was quite hard to enroll people for the study because we had to taper them off their antipsychotics, because that would block the 5-HT2A receptor, so potentially block the antidepressant effects and benefits and psychedelic effects. So it was a small portion of our sample, but we found in that group they did just as well, if not better, than the unipolar TRD group. So very rapid and robust effect in the bipolar group. No treatment emergent mania, no treatment emergent psychosis, and the tolerability profile was basically identical between the 2 groups. So for bipolar 2 depression here, it didn't seem to have a safety signal. So we pooled together this pilot data along with Scott Aronson's pilot data, and the team out of led with the team out of UBC, Lakshmi Yatham, and we put together a CHR grant, and we were lucky to get that funded so that we can follow up on this now and do a large-scale phase 2 efficacy RCT, placebo-controlled gold standard type RCT, where both Ishrat and I will be leading sites at CAMH and UHN respectively. So this is just the start. These 2 trials with the open label single arm that Scott Aronson did, and then the 4 that we did here. And we're going to be getting this RCT off the ground hopefully very soon so that we can get some high quality evidence around the safety and efficacy of psilocybin and bipolar. One other really interesting aspect is that we could use psilocybin as a probe to better understand the neurobiology of treatment-resistant bipolar depression. So to preface this, I just want to share this pilot study by the Imperial College group a few years back, where what they found is that that increased amygdala reactivity to negative emotional stimuli was associated with increased antidepressant effects. I'll just say that again. Increased amygdala reactivity to negative emotional stimuli was associated with increased antidepressant effects. So this is very counterintuitive, where usually we think about turning down the volume of the amygdala in response to negative affective stimuli, and for here, using the facial affect emotion task. But they found that in TRD, in their study with psilocybin increases the amygdala reactivity to emotional stimuli, and they found that that was actually a good thing. Conceptually, Robin Carhart-Harris and their team proposed that likely in TRD, there's a number of people where they're overly suppressing and repressing their emotions, and what we need is not antidepressants and antipsychotics to reduce their amygdala activity, but we actually need psilocybin to increase the amygdala emotional reactivity, to allow them to have that catharsis, to get out the emotions that they haven't been able to get in touch with, integrate that into integration psychotherapy to lead to actual antidepressant effects when they could work through that subconscious or unconscious material. So we're putting this to the test in bipolar depression, where I think, even more so, bipolar disorder has for decades been considered the overactive, hyperactive amygdala, where both in the manic side as well as the depressive side, it's this increased emotionality that we see to emotional stimuli, where mood stabilizers across the board more or less reduce the amygdala activity. And mood stabilizers are very effective for for bipolar depression for some people. But if you're in the camp of treatment-resistant bipolar depression and conventional mood stabilizers and antipsychotics have not been helpful, maybe it's because we don't need to hammer down your amygdala even harder, but we actually have to increase the volume of your amygdala so that you can work through those emotions through the integration psychotherapy here. So this is something where this was funded by the Labatt grant, where this is neurobiologically focused, where, of course, in this study, we're going to be very interested in the efficacy and safety outcomes, but the primary outcome here actually is to determine the same as the unipolar study, where we want to see is it a good thing or a bad thing for us to turn up the amygdala reactivity with psilocybin to negative emotional stimuli in bipolar depression? So, this is a study that we're very excited about that hopefully will be starting soon. And this was supported by the Department of Psychiatry through the Labatt Brain Health Grant. So this will be separate. So, I think this is an opportunity for Canada to really lead, where, now we're seeing, so we're going to have the RCT opening soon. We're having this study opening soon. We had the, 4-person pilot that I presented before. So bipolar disorder has been an exclusion criteria for psilocybin studies, but I think this is a real opportunity for us in Canada to be global leaders, to say that we're going to toe the line, even though this is higher risk research, that it's worth it because this group is suffering so greatly. So a lot of this work is around advocacy, where we don't want to be overly cautious and exclude people that might benefit from this, but we need to be doing this in a safe setting. So that's something that we're very excited about. In the last couple of minutes, I'm just going to briefly cover ketamine for bipolar depression. So I'm not going to be going over the background of ketamine. I think there's been many, many grand rounds on this lately. So I really want to just focus in on ketamine for bipolar depression specifically. But just briefly, the context, this systematic review recently published found 49 RCTs. So it's been very well established now that intravenous ketamine and intranasal S-ketamine has a rapid and robust antidepressant effect with a large effect size of around 0.73. The problem as it pertains to bipolar disorder is that bipolar disorder has been an exclusion for the large majority of these trials. So the conclusions about ketamine for depression so far have been mostly specific to unipolar treatment-resistant depression. We conducted this systematic review published last year, where we found that there's actually only been 3 small single-dose RCTs looking at ketamine for bipolar depression. So these are tiny numbers, 15 to 17 people, and there wasn't the repeated doses that we know is required for ketamine, but just single-dose studies. So very small single-dose studies that have been done in terms of RCTs. There has been some open label studies that are slightly larger, with the largest one globally to date being from our group with 66 people. That was published last year as well. But all of these are open label with all the limitations that are associated with that. So, really, when you compare this to the 49 RCTs in MDD, it's really sort of still early days, I'd say, for ketamine for bipolar depression. So this is that largest study to date with 66 people that we were looking at the real world effectiveness in our clinic sample at CRTCE. And just for some context, this is a 4-dose intervention where it's twice weekly for 2 weeks. And right at the beginning of starting this clinic, Roger McIntyre had set up this very nice measurement-based care setup so that we had IRB approval to collect all this data as well, and everything was being collected into REDCap, so that it's created this really outstanding data set that we've been able to interrogate from several different angles, including looking at the patients with bipolar depression. So in the sample, 66 people. What was unique as well as this was the first one that looked at bipolar 1 and bipolar 2 separately, and it was a fairly even split between the two of them looking at ketamine in this group. And what we found is that in the total sample, as well as in the individual samples of bipolar 1 and bipolar 2, that there was rapid and robust antidepressant effects that was both statistically and clinically significant. There was a trend towards greater antidepressant efficacy in bipolar treatment-resistant bipolar 2 depression that did not reach statistical significance, but likely we were underpowered to do that comparison since it was only about 30 people per group. But this suggested that, in both groups and bipolar depression overall, that there is antidepressant efficacy in this naturalistic sample. There was further improvements with each infusion, which is what we've seen with unipolar depression as well, that, one infusion isn't enough, but with each subsequent infusion, you have further and further reduction in depressive symptom severity. We also saw a reduction in suicidality and suicidal ideation, which of course is so important for bipolar disorder, with people dying from suicide at rates of 5 to 10% in bipolar disorder. So this is where we really need an intervention for reducing suicidality. Of course, this wasn't able to determine if we reduced completed death from suicide, but suicidal thoughts based on the QID suicide item self-report measure, we found this reduction. Tolerability was good as well, where it was basically comparable to the unipolar depression group. There were 3 cases of treatment-emergent hypomania, and there was 0 cases of treatment-emergent mania or psychosis. So, 5% risk, so that's not insignificant. So I think it is important for people to be on mood stabilizers if they're pursuing ketamine therapy and have a diagnosis of bipolar disorder. But this is far from 50% or really concerning numbers. So most patients would say that they're willing to take that 5% risk, and of course we can do some things to mitigate that with having them on a therapeutic dose of a mood stabilizer as well. So using this pilot data, we were able to secure 2 grants to study this further. So CIHR funded our RCT, and then we quickly submitted to PSI to fund an add-on study where we looked at repeated doses for relapse prevention over the course of 3 months. And we're very grateful that both of these studies were funded on first submission, which I think just speaks to the relevance of this topic of that there's such a huge need. We need better treatments for bipolar depression. We need better treatments for suicidality in this group, and there's such promise with ketamine in this group. So this is the RCT that we're doing right now. It's 4 doses, and it's actively enrolling. We're well along, but we still have good room for recruitment. So feel free to refer to the Depression Center at UHN. We've recently onboarded Ontario Shores as well for people in the East End. And then this would be the maintenance portion, where over the course of 12 weeks, for those who responded to ketamine, they would be able to get repeated doses to try to maintain the benefits, where there's actually been 0 studies on ketamine maintenance treatments for bipolar disorder. So it's a provocative question too, in terms of could ketamine maybe even be a mood stabilizer, where it's effective in the acute treatment of bipolar depression, but maybe it can also be effective for preventing relapse of depressive episodes in bipolar disorder as well. So to briefly summarize, certainly there's theoretical concerns about treatment-emergent mania and psychosis that have really limited the investigation of ketamine and psilocybin for bipolar disorder. But given the great need in this group, I think it's imperative that we don't have that knee-jerk reaction to say we're never going to study in this group. But within the context of very rigorous safety monitoring, I think we should toe the line and investigate these new interventions in bipolar disorder. Just small RCTs and open label studies for ketamine as well as in psilocybin, and there seems to be low risk of manic switches, but we need those rigorous phase 2, phase 3 RCTs. For psilocybin specifically, there's just the two small pilot studies that I discussed, the one from our group and the one from Scott Aronson. Major limitations that Ishrat highlighted very well. And then there's the issue of lack of long-term data as well. So I want to open it up for questions at this point. I'll just stop the screen share so we can interact with each other.
Great. Thanks a lot, Josh. We have a question in the chat, which I'll come to in just a second, but maybe just to start off, obviously this is, especially I'm referring to psilocybin, but can be ketamine as well. Such a hot topic that people in the community are getting access to this. So my question to you both is what your thoughts are on the promise and peril, and also how clinical research can stay abreast with the interest, not going too fast, going too slow. So how do you balance the fact that the horse has left the barn a little bit with this need for rigor?
I mean, I think the horse has left the barn. And I think a part of our role is also to do as much harm reduction as we can as well. So I think that, that's a key part of it. I mean, I work still clinically in the CAMH emergency department, and I see young people with psychotic illness or bipolar illness coming in with hallucinogen-induced psychotic or manic symptoms. That's anecdotally, but I think that our role is to sort of part of it is to provide psychoeducation and harm reduction strategies to patients. I think that every time I've just had a patient last night email me whether they should be accessing an underground guide to do psilocybin therapy. I always tell them, I toe the line and say that it's still an experimental treatment and it should be restricted to clinical trials at this point. But I appreciate that at the same time, patients are desperate and they can't wait for research to catch up. And so, I know that there are groups that are, particularly clinics in Toronto, that are applying to Health Canada for special access. And it's happening pretty rapidly. My understanding is it's only like a few weeks of a wait time now. I don't know if that answers the question, Ben, but that's kind of that's what my thoughts are with this whole area. Josh, do you have anything else to add there?
Yeah, it's two minor comments. One is the biggest thing I find just emphasizing, informing, and providing the education is that psilocybin is not legal. I think there's so much misinformation out there that so many people, they see shroomies, and I mean, it's shocking that these people have storefronts they're renting, these are, illegal businesses. So that's just an important piece of information, that it's not like cannabis, it's not legalized yet. So because providers also, I think, often are not aware of that. So they're saying, oh, well, you can try it. There's a store down the street sort of thing, but it's not legal at this point. So that's an important just a fact of information. And then the other thing is just sort of in terms of, as researchers here, we see everything going on, but we have to just sort of keep going. And it really increases the amount of rigor that we have to have. And, very regular checks that we're having on our team is making sure that people aren't presenting themselves in a biased way to participants that could bias the results. And, very much coming at this from an agnostic perspective of, we don't know if this is effective. And we need to be holding ourselves in that way in every single participant encounter that we have.
Thanks for the balanced answers. There's a question from Sherry Zenner. Would you consider a trial of psilocybin for patients with conversion or dissociative conditions? And then regarding the PowerPoint, Sherry, we're going to make the videos available after this presentation. You can reach out to Jessica Barton if you have any further questions. So for conversion or dissociation, what do you guys think?
We're actually discussing the trial of somatic symptom disorder for psilocybin therapy, which is, I mean, we don't really use the conversion anymore, but somatic symptom disorder would sort of fall under that umbrella. It's not my area of clinical expertise, but I can understand sort of that, it may provide some insights. I could see how that would work, or how it could sort of help people with that cognitive inflexibility.
Yeah, great. A very interesting research question. These are complex illnesses that likely require complex interventions, and I can't think of a more complex intervention than psilocybin-assisted psychotherapy. So yeah, I think it would be great research studies to do.
Thanks. Don't see other questions in the chat. I have another one for you, if you don't mind. So in terms of the representativeness,
I think, Victor and Benoit might have their hands up.
oh, sorry about that. Go ahead, Victor.
Time, sorry.
Oh, hey, great presentation, guys. I think you're killing it, and it's great to see that, the evidence is going to come, as much as it's needed. So, I like the approach that you're taking with the inclusive kind of criteria to make it more real world effective, and, including comorbidities and things like that. I'm trying to do that with the trials that I'm doing too, is that, the headliner is the one um, disorder, but, you're inclusive of other things, so you can hopefully collect some information on that. But, you anticipate up front that there's going to be some problems with that later on. So, I mean, it's like two things. So one is kind of collecting outcomes on those other diagnoses. So are you basically administering scales for whatever else, trauma, BPD, everything else when you're like conducting these trials? And then the other thing is kind of, do you think about for like, if the ultimate aim is for some sort of regulatory approval or, level one evidence or something like that, it gets affected by having not a trial that was done that you can demonstrate was purely in that disorder alone?
Yeah, maybe a couple quick comments. So there's always a massive fight around what outcomes to collect, and so we just are judicious about the highest yield ones while not increasing the burden. So we're not collecting everything, but the things that we think are most important we collect. And then yes, it's a really good point around when you are including a bunch of these comorbidities, it causes a lot of problems if you want to use this data for regulatory purposes. And that was actually in the paper that was published yesterday, where we emphasized that in discussion that this RCT will not be able to contribute to the efforts towards regulatory approval. But that's why we're doing both. So the RCT for bipolar depression that I mentioned is going to be a very conventional phase 2 RCT that would be usable towards regulatory approval.
Okay. So it's not quite the same for the inclusion criteria then for this trial as the one that you just published.
Exactly. Yeah. So we have to sort of do both.
Yeah. Okay. Thanks, Josh.
Thank you. Ishrat, anything to add to that?
Yeah, no, I think that's right. I mean, that same applies to unipolar TRD. I mean, Compass is doing those phase 3 trials with very restrictive eligibility criteria, but I think the real world data is also really important.
Benoit, did you have a question?
As we are talking about real world data, Josh, when you talk to us a very nice clinical setting with MBC, are you talking of the Brexia clinics?
Sorry, for the ketamine data that I was sharing? Yes, that's the Brexia clinics.
So again, not to be the hypercritical Frenchman, this is not a representative sample. I have a few patients who got their ketamine there. You guys charge a lot of money, and those people have a lot of service. They don't look like the other patient with TRD that I treat. So, I mean, scientifically, if we believe the brain is the brain, it should make a difference. But in reality, we know that the social determinant of health, the poor patient do not as well as the rich patient. So the data you show from Brexia are probably the best you could get because it's a very advantaged group. That was my question, comment. Thank you for clarifying.
Yeah, agree completely. And it increases expectancy as well. If you're paying a lot for a treatment, that's going to increase the expectancy. So it's on both ends, that it's a biased sample as well as biases the outcome sort of stacks it up. For sure, definitely agree.
So it's an upper bound like our efficacy trial. So we talk about efficacy and effectiveness, but doing an effectiveness in a very unrepresentative sample is not ideal either. And at the end, that's why we need a lot of data. And then when you have a lot of data, meta-analysis can tell us where the truth is probably. Anyway, thank you for your presentation, both of you.
So thank you, Ishrat and Josh. I think that was great to hear your level of scholarship and knowing the literature and knowing the mechanisms and also being deeply involved in these trials, partnering and doing that. I think we'll get other questions. There's one more in the chat, but a couple of reminders to folks about our next presentation, April 4th, on psychotherapy and bipolar disorder. CME credits are available for this. And please join us next time. Thank you again, guys.